Hi, I'm Dr. Jared Gardner, and today we're going to talk about actinic keratosis and squamous cell carcinoma. I made a basal cell carcinoma video a couple years ago, but I never made a squamous cell carcinoma one, and people keep asking me why, and the answer is it's a lot more complex and nuanced than you might think. These seem to be, they're very common bread and butter lesions that we see numerous times every day in dermatopathology. But sometimes sorting them out can be a little bit tricky, even when you've been doing this for a long time. So I'm going to start with the basics of what we're talking about with actinic keratosis, squamous cell carcinoma in situ, and invasive squamous cell carcinoma. And then I'm going to run through a whole bunch of different cases showing you kind of all the variations and difficulties that can come up. And hopefully that'll give you a place to start. So this is an actinic keratosis. These are due to ultraviolet radiation damage, usually not just occasional exposure, but years and years of exposure. Basal cell carcinomas can grow from intermittent high-intensity sun exposure, but usually actinic keratoses are in people with a significant amount of chronic sun damage. You can see that's the case here. Look at the dermis. The dermis is totally blue because it's all replaced with solar elastosis. And that is not just from occasional trips to the beach. That's working out in the sun day in and day out every day for decades that gives you that, okay? And from low power, you can see that the epidermis, even though it's atrophic, it's got loss of the reedy ridges. You can see that there's parakeratosis over top of it. Even if you can't tell that there's nuclei there, there's thick, bright pink keratin in the corneal layer that's thicker than usual. On a sun-damaged skin biopsy, when I see thick corneal layer, the first thing I think of is it's probably going to be an actinic keratosis. And these lesions are, they're dysplasia, they're precancerous, and again, they're due to chronic sun exposure. A small subset of them can progress into carcinoma. Most of them probably do not, but some of them can. And so they tend to get biopsied either if there's concern clinically that they might be cancerous, or if they've tried to treat the lesion with liquid nitrogen or something like that, and then it's still persisted or recurred. All right, so the parakeratosis is a helpful feature. At higher power, you can tell that there is atypia. Large atypical keratinocytes here, kind of jumbled and disorganized. Compare that with the normal keratinocytes here. Go a little bit closer even. The normal keratinocytes are small and uniform, but here you suddenly get large atypical nuclei, sometimes increased amounts of pink cytoplasm, and the nuclei are all disorganized. Instead of making a nice uniform layer along the basal layer, there's all this jumbled, some people say wind-blown or disorganized atypia there. But as you go towards the top, the atypia is not full thickness. You still have development of a flattened layer of squamous flat cells at the top here before you get to the corneal layer. So that's the distinction, is that actinic keratosis is atypia that's down in the lower parts of the epidermis and not full thickness. Now that might sound simple, but actually that's where in real life practice that can actually become quite challenging. Especially here, look, the whole epidermis is what, 5 cells thick? So there's an atypical cell at the top. Is that squamous cell carcinoma in situ? What about over here? There's one atypical cell getting all the way to the surface. Is that in situ? So it can actually become a little bit subjective. I think you kind of just have to look at the whole lesion and make a distinction based on the gestalt, the overall appearance, and also how big the biopsy is and what your level of clinical concern is. So I think that this is a really nice example of actinic keratosis here. And AKs, AK is our abbreviation for actinic keratosis. AKs tend to spare the adnexal openings. So the hair follicle openings and acrosyringia, the openings of the sweat ducts, they usually have normal looking keratinocytes around them and a relatively normal corneal layer over top. You see the parakeratosis stops right here, the atypia stops here, then you have normal, and then you're back to the actinic keratosis. So that sparing of the adnexal openings is a feature that we often see in actinic keratosis. One thing you might wonder, I think I wondered a lot at the beginning, is how do I know those aren't melanocytes? They're big and atypical. Could this be melanoma in situ? Well, I feel like it's almost too good to be true for melanoma in situ. And melanoma in situ the atypical melanocytes are spaced out a little bit, and then if they're only single cells, they'll be spaced out usually. If they're totally confluent like this, there's going to usually be nests or unzipping of the epidermis from the dermis, other signs to show you that you're dealing with melanoma in situ. If you have any doubt, you can do immunostains, of course, and I've got a whole video about melanoma that you can go and watch. I'll put a link down in the video description down below. So this is more actinic keratosis out here. All right, so that's AK. So let's now move and see what the next step up is. Here we go. So the epidermis here, you can see normal over on the right. And then over here we have acanthosis, a thickening of the epidermis. And the epidermis is way more cellular than usual. Look at the normal layer over here. And then over here it's very hyperchromatic because there's a bunch of nuclei that are large nuclei and they're packed closely together. They're hypercellular. And you can also tell the change in the corneal layer. Look at this nice basket weave stratum corneum here. That's kind of nice and lacy. And then look here, we got a dense, thick band of parakeratosis. Again, even if you can't see the nuclei, you can tell probably it's going to be para. And of course, look, massive amount of sun damage. If you're thinking something might be actinic keratosis, but you don't see any solar elastosis, maybe take a step back and rethink that, because usually when I make a diagnosis of actinic keratosis, there's solar elastosis underneath. And if I don't see that, then I wonder, well, could this be something else that's causing the keratinocytes to look atypical? And the same is true usually for squamous cell carcinoma in situ, although sometimes you do see it outside the setting of sun damage. So here though, you can tell this is full thickness atypia. There's atypical keratinocytes going from the top to the bottom. Sometimes it gets a little vacuolated artifact like this at the top. And the granular layer is usually lost in both AK and squam in situ. Usually the granular layer is diminished or lost, and then instead of orthokeratin, you have parakeratosis. But that's not always true, and we'll talk about that and show some exceptions a little later. This is a really nice clue for squamous cell carcinoma in situ, pagetoid spread. Atypical cells that are scattered and spread up into the epidermis and out away from the main tumor into the adjacent epidermis. So pagetoid spread is, to me, a really helpful clue to squamous cell carcinoma in situ. And again, you might say, well, melanomas have pagetoid spread, and so does Paget's disease of the nipple and of the genital area. How do I know it's not that? Well, melanoma and also Paget's disease almost never make full thickness confluent zones of atypical cells. They have lots of pagetoid cells that can sometimes almost fill up the epidermis, but I would say it's extremely rare to have just this solid block of atypical cells filling zones of the epidermis. So if you only had this on a biopsy, you may want to do a stain to make sure it wasn't melanoma, or if you were in the groin or the nipple, you could think about Paget's. But if you see this, I feel like I don't need immunostains there. I know that this is squamous cell carcinoma in situ because of that full thickness atypia right here. All right, so if we look elsewhere on this slide, here's what we're going to see. We had in situ here, and now we've got invasive squamous cell carcinoma. Here's the squamous cell carcinoma in situ, full thickness atypia, and then as we come over here, you can see that it invades down into the dermis. And it's got some necrosis in the center of these nests, and also dying keratinocytes that leave these blobs of pink keratin there, which help us decide that it's actually a squamous cell carcinoma when it's producing a lot of keratin. That's not always true. Sometimes basal cells and other things can produce keratin too. Notice something here. There is no atypia in the epidermis over top of the squame. There is no actinic keratosis or squamous cell carcinoma in situ. This is just normal looking epidermis, maybe a touch atrophic, but the point I'm trying to make here is that you would think that it would be this stepwise progression from actinic keratosis to squam in situ to invasive squame, but in real life that is not always the case. In fact, it's often not the case. Sometimes you have invasion with only a little connection to the epidermis. Sometimes you have actinic keratosis that jumps straight to invasion without ever becoming squam in situ. Sometimes you have squam in situ off to the side, but you don't really see it right over top of the invasive carcinoma components. Okay, and this one's kind of bluer than usual, and I'm going to again show you a lot of different examples of squame in this video. Some squames are very pink and glassy and obviously keratinocyte. Some of them look darker blue like this, and those you might wonder, oh, could this be basal cell carcinoma? And that distinction occasionally can be a little tricky, and it does sometimes matter for patient care because squames tend to be a little bit more aggressive than basals and sometimes require a more definitive treatment than a basal cell carcinoma might. One thing to help me is not only is there a lot of keratin production and the cells are pretty ugly cytologically here, but also there's not really any basal palisading around the outside of the nest, and there's no clefting with mucin in it. And those are all features that help me favor basal cell. And again, I've got a whole video about basal cell carcinoma, so I'll put that link down below in the description, and you can go watch that if you haven't seen it yet. All right, so invasive squamous cell carcinoma. So now let's run through a bunch of different examples to show you some variations on these themes. All right, this one's kind of blue, and some of the color variation too depends on the H&E stain that your lab does. I've collected these from a variety of different labs, and sometimes the keratin is very bright pink, and sometimes not as much. Sometimes the keratinocytes are more blue, sometimes they're more pink. So it can actually vary. Here, the reason I want to show this is that from low power, if I can keep it from falling into the microscope, sorry, it'll have to be at a little bit of an angle. From low power, you can tell there's a little bit of acanthosis. The rest of the epidermis is very, very thin and atrophic, but here you can see kind of budding of reedy pushing down, and again, you can sense this tiny, thin layer of bright pink keratin, and so to me, that makes me think right away of actinic keratosis. And when we go closer, another good example of the atypical kind of jumbled, slightly busy look that the basal layer has. The basal layer looks like there's too many cells in here, and so it looks kind of jumbled, disorganized, busy, whatever name visually works for you, use that. Just find the name that works for your mind, and then that can be your visual clue. So that's actinic keratosis there, and over here you can see more of the basically normal or normal for this sun damaged person, but this is their non-actinic keratosis portion of the epidermis, and there's the actinic keratosis. Now here you can see actually that some of the AK is starting to extend down a follicle. We actually see that really commonly, and that by itself doesn't mean that it's necessarily squamous cell carcinoma in situ, at least not in my opinion. And again, different people hold different views on some of these things and on what the threshold should be between calling something AK versus squam in situ. So I'm sure that you can find people to disagree with some of the points that I'm going to make in this video, and that's okay. We all have different ways of approaching dermatopathology. Here's an example that's a little thicker and has a thicker layer of keratin over top of it. The perikeratosis is it's more hyperkeratotic here, but you can still see that the openings of adnexal structures have a tendency to be spared and have some normal corneal structure over top. And there's atypia. Again, it's jumbled and hypercellular, but still seems to kind of flatten out as you get towards the surface. And this is a nice example again of seeing AK, normal, and then more AK. Sometimes AKs have elongated reedy, and sometimes they're very flat and atrophic. It can really go both ways. You can have very thin, flat ones. You can have ones that have elongated reedy, and you can have ones that involve the adnexa and ones that spare and go around the adnexa. Another nice example to contrast between the actinic keratosis here and then the normal opening of the hair follicle there. And that's just one more example, but I think that we've made the points. All right, let's look at something else. All right, here's a case. This is just a dilated follicle that's kind of plugged in the middle here that's involved. But in this case, there's the actinic keratosis. not super atypical. So the atypical can really range. Sometimes it's relatively subtle kind of jumbling, and other times you have really big atypical nuclei. The reason I wanted to point this one out is look at the pigment in here. There's melanin pigment. So sometimes actinic keratoses can be quite pigmented, and when they are, occasionally, especially if they're not very scaly, clinically they can sometimes resemble melanoma in situ. And so they may be biopsied with a differential of rule out lentigo versus lentigo maligna type of melanoma in situ. So here, notice the basal layer here is kind of pale and different colored from the rest of the epidermis. And it's a little bit of that jumbled hypercellular, a little bit atypical. So to me, this is part of the actinic keratosis, but it's kind of surprising that there's no para over top. So again, we teach that usually you have loss of the granular layer and parakeratosis in actinic keratoses, but sometimes we see ones, particularly it seems the pigmented ones, that tend to not follow that rule. And so you could also make the argument that maybe this whole thing is just a solar lentigo, and that it's a solar lentigo where you have a little bit of basal layer atypia just because it's been cooking in the sun. Whichever way you want to go with that argument, it doesn't really matter. The point is it's not melanoma. And out here, look, we do have stuff that looks actually less atypical and much more like a regular solar lentigo with, let me see if I can get it into focus here, with increased melanin pigment in the basal layer keratinocytes. But then look, there's a couple atypical cells in here. So instead of having a bunch of angst over do I call this solar lentigo or pigmented AK, oftentimes what I use for these personally in my practice is I say pigmented actinic keratosis and solar lentigo, and I use that as my line diagnosis in the report because they often intermingle together. I feel like you often see pig AK and solar lentigo right next to each other, kind of mingling in and out of each other, and telling where one ends and the other begins is not really easy. And again, it doesn't really matter because the main thing is clinically they're biopsying a pigmented lesion on a sun-damaged person because they want to rule out melanoma in situ. Now, this is an actinic keratosis that's very thick. The epidermis is thick and acanthotic, and also the corneal layer is very thick. So you can call this either hyperkeratotic actinic keratosis or hypertrophic actinic keratosis. Some people make a distinction about those. The abbreviation we use for this is HAK or HAK. So in my practice, at least, that's what we often, in Dermpath, we have lots of long names that are Latin, and so we use lots of abbreviations and acronyms. HAK, or hypertrophic AK, is a really common specimen. I see it very often, and the reason is because these lesions are thicker, clinically, it can be harder to tell, is this an actinic keratosis, or is this actually squamous cell carcinoma, because it has more substance to the lesion. And the most common place that I see these is on the dorsal forearm, dorsal hand area, because after the face, the dorsal forearm and hand are the most highly sun-exposed areas on the body for most people. Think about the back of your hands and your arms. When you're outside anytime, if the sun's out, you're getting sun exposure there. If you got short sleeves on, even if you have long sleeves on, your dorsal hand is still getting sun exposure when you're driving in the car or whatever you're doing. So a lot of times you see just a massive amount of solar elastosis here, and you tend to get these very thick, hypertrophic, hyperkeratotic actinic keratoses on that location more than anywhere else. I want to point out something from low power. Look at this amazing sparing of the adnexal openings, the acrosyringia and the hair follicles. You can see even from low power how these keratinocytes are clearly normal compared to these, which are actinic keratosis. These big glassy ones here are very different from these right here. And you can see this reflected in the stratum corneum. This thick, pink solid block of parakeratosis suddenly turns into a different color of keratin. Now, I'm not exactly sure why this happens. This is not like the normal loose basket weave stratum corneum. This is a thick layer of stratum corneum, but it's got kind of a purpley blue color. And if we go closer, you can see that it's got no nuclei retained in it. So let's see if we can get that to show up on the screen here. We'll flip the condenser. Yeah, there you can see all the nuclei retained. These little dots, those are retained nuclei. in this parakeratosis, but this layer right here doesn't have any. And so I've had trainees ask me, well, why does it turn kind of blue like this? I honestly don't know the answer. I think it's because the skin on the dorsal hand is kind of close to the acral skin, like the palm, and in the palm and sole, you tend to get a little bit of this bluish look to the stratum corneum, and I feel like the skin on the back of the hand has that same kind of, some of those similar properties. So I don't know enough. There are people who are experts in the cornification process, and it's really complicated actually, and way beyond my knowledge at this point. So anyway, what we call this is the flag sign, and it's depending on what kind of flag. I'm an American, so I think of an American flag, that it's kind of the red, white, and blue, that these are the red and white stripes, and then here's the blue field with the stars. You know, again, in Dermpath, you have to have a really good imagination about things, and pretend that you see stuff sometimes. I've also seen people that say, well, it's like some of the countries have 3 vertical bars as their flag, and so it could be representative of a flag like that. Whatever works for you is fine, but just know that this alternating bright pink para and then bluish, purpley red orthokeratin is a really good sign for actinic keratosis, and I particularly see it in these hypertrophic actinic keratoses. So let's go a little closer and look at the cytology of these cells. Even though really these are low power diagnoses oftentimes, for the sake of learning here, we can explore this and investigate a little closer. Again, you've got atypical large nuclei that are jumbled along. Look how cellular the basal layer is, right? Very jumbled and disorganized. But then as you go up, the cells become more glassy. They have abundant homogeneous pink cytoplasm. When we say glassy in regards to keratinocytes, that's what we mean. Lots of dense, smooth, homogeneous pink cytoplasm because they're full of keratin filaments. In this case, it's keratins 1 and 10, which are the main keratin filaments in the spinous layer keratinocytes, whereas keratins 5 and 14 are the main ones in the basal layer keratinocytes. And then as you get all the way up to the top, again, the cells start to get smaller nuclei, they start to flatten out. They don't have atypical hypercellularity all the way up to the top like you would in a squamous cell carcinoma. And note that the granular layer is diminished and really pretty much absent here, and then you've got parakeratosis. And anytime you see that, the basic, I think I talk about this in my normal skin histology video, but that, you know, normally the epidermis, as the keratinocytes move from the basal layer to the top, they develop a granular layer, and then in that process they break down their nuclei and die, and then the dead keratin goes into the top to make the stratum corneum. When the epidermis is growing too quickly, it doesn't have time for that granular layer to develop, and therefore the nuclei get retained and trapped into the stratum corneum and pushed up out of the top. So anytime you see parakeratosis, it's usually kind of a surrogate marker for telling you the epidermis is not maturing normally, either because it's growing too fast or because something else is wrong with it that's not allowing it to mature in the right way. So again, you can see the a little bit thicker layer over here, but still matures as you get to the top. So this is actinic keratosis, not squamous cell carcinoma in situ. It's AK. All right. Oh, I thought this one actually really does look like a USA flag a little bit to me. It's really got like the blue box in the corner and then the red and white stripes out to the side. So if you want a flag sign, this is probably the best example that I've seen. And again, look, just like this is a different case, but it's got the same features. You can see that really nice flag sign there, the thick layer of para. The epidermis is very acanthotic, but the atypia is mostly down at the base and these elongated redi. And then here's a good example of comparing and contrasting the actinic keratosis here on the right with the relatively normal epidermis on the left. Although you can see the granular layer is quite thickened here, and that's because this has been scratched and rubbed. So this is a little bit of lichenification, or Lichen simplex chronicus change, which is the chronic reactive change that the skin gets from repeated scratching and rubbing. And when people have AKs or squamous cell carcinomas or many different lesions, people tend to pick and scratch at them. And I feel like people especially do that if it's on their dorsal hand, because it's right there and it's exposed all the time and it's right by their finger fingers, and I know from relatives I've had watching them kind of pick at their actinic keratoses on their dorsal hands, and I think that it's a very common thing. And so, I mean, almost always I feel like I see lichenification or lichen simplex chronicus reactive changes adjacent to actinic keratoses and squamous cell carcinomas, particularly when they're on the dorsal hand. All right, some other variants here. Here's an actinic keratosis. Again, kind of lichenified, reactive change over here at the side. And then here's the hack, hypertrophic AK. And then something kind of special happens in this one. The cells all start to fall apart. You've still got that layer of atypia along the base, jumbled and hypercellular. But then here the cells are rounding up and getting very bright pink and falling apart. So this is acantholysis. And I would regard this as an acantholytic actinic keratosis. You can have acantholysis in a variety of benign and malignant and premalignant keratotic lesions. So in this case, I don't think that there's full thickness atypia or anything else to call this squamous cell carcinoma in situ. We do see acantholysis sometimes in actinic keratoses. I think it becomes a little more challenging, though, when you see this pattern, to know if there's full thickness atypia. Because look, from here, it's hard to tell. How do we know if there's full thickness? Because the rest of the epidermis above here is gone. So in areas where you have either acantholysis or if you have excoriation or ulceration, it can sometimes be challenging to tell if there's full thickness atypia. And the general approach that I use, and it doesn't always work, is I try to look away from that area. Is there anywhere else that's intact where I can see full thickness atypia or pagetoid spread or something else? And if there's not, then usually I kind of back down and ignore areas like this and don't try to say, oh, that's full thickness because the epidermis stops here and there's atypia all the way there. So I try to not judge those areas as much, and I look over to the periphery and see what's the rest of the lesion look like. And here the rest of the lesion looks like actinic keratosis. That's my approach, at least. Here's another example of actinic keratosis. And the reason I want to show this one is because you can really nicely see how it extends down hair follicles. So you can see the actinic keratosis here. These atypical cells are just coming in and they're running straight down the edges of the follicle. They don't fill the whole thing up usually. They just kind of bulge down the edge, and the center of the follicle is still there. So this can be problematic, especially when you get, oh, here's some more over here. These kind of budding of the reedy. And sometimes people use terms like proliferative actinic keratosis to describe actinic keratoses where there's a bunch of reedy that kind of bud and push down into the dermis, but that don't seem to really invade. I used to use that term, and I found that it often confused my my dermatology colleagues. They wondered, well, what do you mean? Like, what should I do about this? So I usually just don't say it now. I just decide if I think it looks like an actinic keratosis or not. If there's a lot of extension down hair follicles or sweat ducts, I will sometimes say that there's a adnexal extension. And the main reason for that is I think sometimes those AKs can kind of regrow after you've shaved them off because the atypical cells are still down there. I don't know if that's totally true, or you could argue, well, that means it's squamous in situ, and again, we could have debates all day about that. But I do bring up if there's a significant amount of adnexal extension, and the particular time I like to bring that up is like this. What do we do with the lesion here? If this were all we had in the biopsy, what do we call that? Do we call that squamous in situ? Do we call it AK or invasive? I don't see definitive invasion there, but boy, it's pretty busy and budding down, and I can't see the base. It's transected, and I know that it's growing down follicles some. So what I tend to do in things like this is say at least actinic keratosis, or at least actinic keratosis with adnexal involvement, with the point being, and I know that may be a little frustrating for my dermatology colleagues, but I feel like it's honest. I'm saying I can't see what's happening below. I know that what's here doesn't really meet criteria in my mind for in situ squamous cell carcinoma. Looks like actinic keratosis, but I've got a thin transected shave that's not showing me what's happening below. So then that gives my dermatology colleagues the option of either, if they're worried about it, they can go back and do more. Otherwise, they can follow it and watch, and if the lesion persists or grows back, then they can go and biopsy it again or do something more definitive. I try to avoid using this, but sometimes there's just no way to decide for sure because I can only comment on what I can actually see in my biopsy. And that's again why it's important to have a good rapport with your dermatology colleagues to find out what terminology works for them, what way they like you to phrase things when you're having trouble deciding or figuring out what's going on. And always, of course, to encourage them to call you if they have a problematic case where hey, you know, we really need to know what do we need to do next to figure out the situation. That's just a general good rule in all of Dermpath and really in all of pathology. Here's another case like this where here we've got nice hypertrophic actinic keratosis. Starts kind of budding down and pushing down, like right here. So is that invasion? Well, it kind of looks like it, right? But be a little bit careful here because we're kind of tangentially cutting or obliquely cutting through the tissue. And you can tell because we've got little islands of entrapped papillary dermis. There's little islands here. So you really have to be careful of deciding for sure if there's invasion when you have kind of tangential cutting, and also when there's involvement of adnexa, then there's a tendency to sometimes get tangential cuts of that where it makes it look like there's islands of atypical keratinocytes in the dermis, but in actuality they may be connected up to a sweat duct like here or over here, right? So when I see a lot of adnexal involvement, I'm a little bit more cautious before calling something invasion. That's just because there's a couple of nests in the dermis. So it may still be invasive, but it's harder to tell when there's adnexal involvement and when there's tangential cutting. And then so the thing is that when you have something that's transected like this, that's the kind of time also where I might say at least actinic keratosis. Now, because especially, what if it was transected like that? What if the shave went right through there? And a lot of times that's what happens, not because the dermatologist is trying to be stingy or not give us a good shave, but because look at this massive layer of keratin on top. So a shave right through here would feel clinically to the dermatologist like they were getting a nice, thick, good shave biopsy. So keratotic lesions, I feel like there's a tendency that they don't often get deep enough on the shave because they feel so thick clinically that it seems like they're getting a good biopsy, but sometimes a lot of the material that's being biopsied is actually just this horn of corneum on top, and actually we can't see the base of the lesion. So so I feel like, so if you're a dermatologist watching this, you know, I know the struggle is real, but on lesions you're worried about, the deeper you're able to get, if you're able to get under it, sometimes that helps me a lot in being able to give a definitive answer. I think here there probably are some nests of invasive carcinoma, but again, it's so tangential and there's so much adnexal involvement that it can be a little challenging to tell for sure. All right, let's talk about squamous cell carcinoma in situ now. So here's a nice example of squamous cell carcinoma in situ. From low power, you can tell the whole epidermis is full and cellular and very dark because there's so many cells filling up the epidermis. Sometimes there's a thick layer of perikeratosis on top, other times not. But you can see the entire epidermis is filled with atypical keratinocytes. In areas like this, sometimes there can be kind of clear cell change or edema. This clear cell change right here, this is due to glycogenation of the keratinocytes. We see that sometimes. Occasionally, that can make us wonder about if there's sebaceous differentiation or sweat duct differentiation like porocarcinoma. But I feel like I see this very often in just in regular squamous cell carcinoma in situ, some clear cell change like that. So I don't get too worked up about that. And again, the atypical cells fill the entire epidermis. They're very blue and hyperchromatic. Sometimes they're monotonous, other times they're wildly pleomorphic. It really can run a range. Like I said, there's a lot of different variations and flavors of actinic keratosis and squamous cell carcinoma. You often will find lots of mitotic figures, and the mitoses do tend to kind of be up higher in the epidermis. If you start looking around, you'll start finding them. But by itself, I don't feel like that's necessarily proof that something's squame. I see sometimes irritated seborrheic keratoses that have a fair number of mites. So I really feel like the low power helps me the most. When I see this thick filling of the epidermis with hyperchromatic atypical cells, that helps me. And here you can see that just like AKs can push down follicles, you can have the same thing. This is squamous cell carcinoma in situ going down this follicle, that follicle. Over here you can actually still see the basal layer of this hair bud is intact, the little outer root sheath, but the inside is filled with squamous cell carcinoma in situ. So it's extended way down this hair follicle here. Now in contrast, I think this is actually a nest of invasion. Look at how irregular it is. It's got little tiny islands that are pushing out and pushing right into the dermal collagen and in between the elastosis. So these are islands of invasion underneath squamous cell carcinoma in situ. So probably those are really invasive. But again, it can be a little hard to tell because you do have a lot of extension down at nexa, like this hair follicle, and then these long reedy. And then look at the wild atypia there. Sometimes the atypia is just massive in squamous cell carcinomas. Here's another example. It's very purple, very elongated reedy from low power. This is a very thick squamous cell carcinoma in situ. And it's densely inflamed. There's a ton of inflammation underneath it. And sometimes there are lots of plasma cells. I see this often where you'll have a sea of plasma cells underneath squamous cell carcinomas and also basal cell carcinomas. I've seen people get really worried about that and think that it's plasma cell myeloma involving the skin. I see that in my practice, but I've never seen it next to a basilar squam. I'm sure it'll happen eventually, but I've seen patients that had known myeloma get skin involvement, and I actually probably see that more than a lot of people, because of the center where I work. But we see regular plasma cells as a reactive phenomenon under basals and squams all the time. And so honestly, when I see this, I don't do any additional workup. I just don't even bother to mention it because I don't think it means anything clinically. And but it does freak out my residents sometimes. But then once I start pointing out to them how often this happens, they're like, oh yeah, I guess it is a common finding. So the other reason I wanted to share this case is this case shows a nice example of something we call the eyeliner sign. So squamous cell carcinoma, when it starts, it'll fill up the whole epidermis, and then sometimes it spreads out to the side and to involve the normal skin next to where it started. It spreads out kind of peripherally into the epidermis. And what happens is it replaces the whole epidermis but tends to leave the basal layer, the normal basal layer, intact. And so from low power, this gives you this look of kind of like a line was drawn underneath here, like a line of eyeliner makeup, or like a kid drew under it with a crayon, however you want to think of it. And if we go closer, you can see. Sorry, I'm having a little trouble with my driving skills today. You can see the atypical keratinocytes in here with mitoses, but then this little layer of uniform, monotonous, normal basal keratinocytes here. So that's a really helpful clue for squamous cell carcinoma in situ. You tend to not see that eyeliner sign in melanoma in situ. And also, like I said before, melanoma almost never, I mean, there's always exceptions to rules, but almost never do you get full thickness, complete filling of the epidermis with melanoma in situ. It's almost, when it fills up a lot of the epidermis, it does so with a bunch of nests, and it leaves normal keratinocytes scattered in between. And then over here, you can see, again, even from low power, I think you can appreciate the eyeliner. See that little line right there? That's eyeliner sign. There's a little line down here too. It can be a little subtle, but with practice you can learn to pick it out, and it's quite helpful. And here's a little bit bigger eyeliner sign. You can really see this is how it's happening. The epidermis is getting filled up with the malignant cells, and it's leaving behind little pockets of normal keratinocytes, and the ones that get left last of all are the basal layer. And then if we go out to the side, I think it's on this piece, you can see that there's a lot of pagetoid spread. See all the atypical, large, pale, malignant keratinocytes up here. This is pagetoid squamous cell carcinoma in situ. And I feel like it's these squamous cell carcinoma in situs that have pagetoid spread, those tend to be the ones that make that eyeliner sign happen. It's because they spread out like this towards the edge, and then eventually this whole field here will get filled up if we wouldn't have taken it away with a biopsy, and then what will be left behind is just a little eyeliner. So squamous cell carcinoma in situ, eyeliner sign. And you might say, look at all the vacuoles here. How do we know these are not melanocytes if we just had this area? Well, I've got a little video about this on my channel too, how to tell melanocytes and keratinocytes apart. But basically, a vacuole with a naked nucleus in the center is almost always going to be a keratinocyte, and melanocytes tend to have cytoplasm stuck to the nucleus and a vacuole around the outside. And I'll put a link to that down below too, that you can go and see if you need a refresher on that. It's actually quite easy, even without immunostains, usually, to tell apart vacuolated keratinocytes from vacuolated melanocytes. And here's another example that's really dramatic in the amount of pagetoid spread that you have. Here it could be harder to tell because you see pagetoid cells, but you don't really see any areas of full thickness squamous atypia in this area. You just see a kind of a lichenified, thickened granular layer here, and then a lot of pagetoid atypical keratinocytes scattered throughout. But when we go over to the side, if we have a big enough biopsy, you'll usually run into areas like this where you can tell there's full thickness atypia there. And now you can see that almost the complete epidermis is filled. And so you might argue, well, look, it's not full thickness. There's a tiny layer of maturation there. When I see this much atypia that's this cellular and there's pagetoid spread, I call that squamous in situ, even if it doesn't have full thickness atypia. That's the way I do it. If I start seeing pagetoid spread in something that looks like an AK, that tends to be a thing that pushes me over into calling something squamous cell carcinoma in situ. And again, there's some more of that kind of eyeliner sign right underneath. Now out here, we have actinic keratosis. Atypia along the basal layer, but maturation at the top. There it gets a little bit harder to tell. It's pushing down follicles, but still seems to mature, so I would still say that's probably actinic keratosis. Here, we're really getting filling of most of the epidermis with some pagetoid spread. I'd call this squamous cell carcinoma in situ. And then now look what's happening. All of a sudden, the keratinocytes are starting to turn really bright pink and have abundant glassy cytoplasm. So when I start seeing a lesion, either an actinic keratosis or a squamous in situ that starts getting really abundant pink cytoplasm towards the base, that starts to worry me that maybe there's invasion, that maybe this is pushing down. And the reason is that when squamous cell carcinomas invade the dermis, when they break past the basement membrane, for some reason they tend to make, have paradoxical maturation. They begin to not look like basal keratinocytes, but look more like spinous layer keratinocytes. And someone much smarter than me once told me that the reason for that is that the contact with the collagen in the reticular or in the underlying dermis changes the genes that are turned on in the keratinocytes, and they begin to turn on more of the keratin 1 and 10 production, which makes them look more glassy and have a more abundant pink cytoplasm, which is like the spinous layer keratinocytes. So I thought that was kind of a cool thing. And here you can really see it nicely. That again, here is you got your in situ carcinoma, filling the epidermis, some pagetoid spread, and then look what's happened. It suddenly gets more glassy, and it's because it's starting to go into invasion. And there's probably invasion underneath. But again, if you have this where it's transected, you might say, well, I know that's squamous in situ. It's full thickness atypia, and there's pagetoid spread, but I really can't tell what it's doing down below because it's transected. So this is a time where if I only had this, I would say squamous cell carcinoma, at least in situ. I'm convinced this is carcinoma, but I just can't tell if it invades or not. So I say, well, I know it's at least in situ, and I can't tell if there's invasion or not because it's transected. So that's the way I word that. And by the way, I don't usually report margins. I'm using air quotes, you can't see me, margin status on shave biopsies of basals or squames. And we did a research study on that with one of our former fellows, Alicia Schneblin, and we looked at things that looked like they had negative, quote, margins on a shave, but if we cut through the block, about 30% or more of them actually had positive margins. So I feel like really you can't reliably tell margins. You can know if it's positive, but you can't know for sure that it's negative reliably on a shave, and most of our dermatology colleagues don't really care in our practice. I have a couple colleagues that do, but most of them are like, it doesn't matter whether you tell me positive or not, I'm going to end up treating this lesion the same way regardless of what you say there. So you have to do what works with your practice and your colleagues, but in our community, we've basically stopped doing that for most of our colleagues, and we have good data that we've published in the Archives of Pathology that actually supports that practice. But when it is broadly transected like this, and I'm not sure if there's invasion, I'll say squamous cell carcinoma, comma, at least in situ. All right, now what about this? This is kind of a thick lesion, but look, the keratin over top is very loose and flaky, and there's really not much atypia at all. So I think this is a seborrheic keratosis, kind of a flatter, thinner seborrheic keratosis. But then look what happens as we go over here. Well, okay, that was a fail. I guess it's the next piece. Here's seborrheic keratosis. And then look at that change. Now the corneal layer has gone from this loose flaky to this dense para, and you've gone from kind of a less cellular to a much more cellular, hyperchromatic, atypical looking epidermis. And that's because this is a squamous cell carcinoma in situ. And oh, by the way, the older name, or a name some people still use, is Bowen's disease. Bowen's disease is essentially a synonym for squamous cell carcinoma in situ. So if you're just starting out in Dermpath and you're not aware of that yet, now you know. If someone says rule out Bowen's, they mean rule out squamous in situ. So here is the seb over here that just happens to be colliding with next door neighbor squamous cell carcinoma in situ. Now this is kind of an interesting one because it gives us a chance to look at two other lesions that sometimes can get confused. This is squamous in situ with full thickness atypia, but there you can see there's atypia and a little bit of pagetoid spread here and there. But then right next door, this is not squamous situ. This is a superficial basal cell carcinoma. I think the nice basal palisading can be helpful, but sometimes that basal palisading can get confused with an eyeliner sign. And also I've seen times where really early superficial basal cell carcinomas can look kind of like actinic keratosis. This little bit of basaloid cells can look kind of like the jumbled atypia at the base in an actinic keratosis. So the one thing that helps me a lot is the stroma underneath. There's kind of this unique fibrotic and slightly myxoid stroma that basals tend to make, and I find that really helpful. And again, it probably doesn't hugely matter for patient care because squamous in situ and basal cell superficial type often get treated similarly. Not always, but often I feel like the distinction is not of a huge importance, but I think it's still good conceptually to understand. These are little islands of basal cell here and over here and here. So this is basal cell on this side, and then it merges into a squamous in situ over here. And there again, that's basal. This is basal with the palisading along the base, superficial basal cell. And in contrast, squamous cell carcinoma in situ. Usually basal cell carcinomas do not have full thickness atypia in the epidermis, but I have seen cases that did, and I've seen cases that were basal cell carcinoma that had a little bit of pagetoid spread. So that alone doesn't totally tell you the difference, but usually if I see full thickness atypia and pagetoid spread, and I don't see good basal palisading, I tend to think it's going to be a squamous cell carcinoma in situ rather than a superficial basal. If you're having trouble, this is one time, again, it probably doesn't matter for clinical care, but if it did, BEREP4, BEREP4, will usually stain basal cells very strongly and doesn't tend to stain squamous cells nearly as much. So in difficult cases, if you need, I can't think it, rarely ever would you probably need that clinically, but if someone said, oh, you really need to tell, BEREP4 could help you probably sort out a squamous in situ from a superficial basal. I've seen that a couple times before where that actually was useful and it made a difference. Okay, a couple other variations here of squamous in situ. This was biopsied as a rule out dysplastic nevus versus melanoma. And the reason is, look at that basal layer, super pigmented. So the basal keratinocytes are very hyperpigmented in this lesion. And if you just focus on that, you might think it's a lentigo or a seb. But look at, for one thing, the corneal layer changes. Here's the corneum, the basket weave corneum from the normal skin. And look, now it's very thin and compact, either ortho or parakeratin over here. And also look, the epidermis here is not as thick. It gets thicker over here, and it's much more blue over here. Again, I wish I could get this light just right to make it work. Maybe that helps a little bit more. Let's go closer to see. That's normal. And that's squamous in situ. Look at how hyperchromatic and atypical. So it's really kind of subtle here because it's atypical but very uniform. All the cells look just like each other, and there's not much. There's actually a kind of a thick layer of compact orthokeratin here. There's not even really good para, and in fact, there's actually, I don't know if you can see it here, but there's actually a granular layer that's nicely retained. I'll tell you what this reminds me of. This reminds me a lot of HSIL, a high-grade squamous intraepithelial lesion, or which is basically the modern name that we currently use now for HPV-driven squamous cell carcinoma in situ or high-grade dysplasia in the anogenital region. But I see similar things that look like HSIL and look HPV-derived occurring on, look, this is like on an old person's forearm or something. So I see this on a regular basis, and it may be that some of these are HPV related, not probably sexually transmitted, just because HPV is very prevalent in our environment, and it's all over everyone's skin probably, and there's so many different types of it. So I suspect that there are some sun-related squames that also may have some HPV derived origin, because I see things that look like the HPV HSIL type squam in situ. So this is a really nice example though of a pigmented squam in situ that can actually be kind of subtle. Here you can see this is a nice transition here. But I think these are easy to miss, actually, if you're not paying attention. There's normal, and now you see the difference? You go from normal right here, and then all of a sudden, that's where the squamous cell carcinoma in situ starts, right there. And this is a nice pigmented squam in situ. But again, look at that from lower power. That'd be easy to miss. So I feel like anytime I see just kind of this darker, hyperchromatic, hypercellular epidermis, I go look closer. Sometimes there's certain sebs that I'm like, it's probably just a seb, but it looks kind of too blue from low power, so I go closer to make sure. And usually once you're closer, you can easily see, oh yeah, there's atypia there. I mean, real pros maybe can do it always from low power, but a lot of times I feel like I need to check a little closer for a second just to make sure and look around for a bit to make sure that I'm not missing something so that I can sleep at night. All right, so there's pigmented squam in situ. Here's a case where, again, from low power, this doesn't stand out. The corneal layer looks thick, but it looks like nice ortho. This is dorsal hand, probably. And so you might think this is just like Lichen simplex chronicus from scratching, or maybe a thin seb or something. But a closer look, it's that same thing. It's those hyperchromatic, atypical, jumbled guys. They're kind of monotonous and uniform, but they're too hyperchromatic and too packed closely together for normal epidermis. Like this would be normal here, and then this is squam in situ. So this is a very, very subtle squam in situ, I think, and I feel like it takes a while to recognize these. And look at the top, it almost looks, to me, it starts to remind me a little bit of like coilocyte change, kind of. Again, this is one of those that has a very much like an HSIL, HPV look to my eye, and I don't report, I just call these squam in situ. I don't know what that means, but I do see some that really have that HPV sort of look, even though they're away from the anogenital area. So I think these are easy to miss, and I've seen ones that actually from low power look kind of like psoriasis. They had a elongated reedy and had a psoriasiform look. This one doesn't really, but so I've seen ones like that where they're really thin and they're really subtle, and those can take a little bit of practice to recognize. And here's another one that is more obviously full thickness atypia, I think. Well, it will be in a second. But the reason I'm showing you from low power here, I want you to see it's got kind of that knuckled look like you would see in a condyloma. But again, this was not from the anogenital region. It was like on the forehead of an older person. And there's clearly full thickness atypia here. But it has kind of, again, an HPV condyloma sort of appearance to it, or shape. And there again, some pagetoid up here that can kind of help you as a clue to see these atypical guys that are kind of spreading up. And some of these really do look, to me, look subtle, but kind of remind me of coilocytes a bit. So we do see that sometimes. If you see something like this, though, and it's in the anogenital area, then I actually call it HSIL. And for my dermatology colleagues, some of them are not familiar, since that's a newer terminology that is more in the gynecology world and less in the dermatology world. So I usually put a comment, high-grade squamous intraepithelial lesion, and then say this is the current terminology that we use for HPV-driven squam in situ, or HPV-driven high-grade dysplasia of the anogenital area, and it encompasses squamous cell carcinoma and boinoid papulosis, which looks basically just like this, but it's really a clinical term. And so I add that comment. And if it's not obviously in the anogenital area, but it's somewhere like, say, inner thigh, where I'm not sure exactly how close it is, sometimes I'll call those squamous cell carcinoma in situ, but I'll put a comment that if this is close to the groin, then maybe it would be better regarded as HSIL. They're the same thing. It's still squam in situ, but the reason is in the anogenital area, it may be treated by a gynecologist or a urologist, and we need to make sure that we use the terminology that they're familiar with. So I think that's the important thing, is making sure you're using the proper terminology for whoever's going to be taking care of the patient. Okay, let's talk about invasive squamous cell carcinoma now. Here's an example And you can see that a lot of times there is perikeratosis over the top of the lesion. And sometimes this kind of creates an indented or crater shape or volcano shaped kind of eruption of keratin out of the skin. And then down beneath this, if you had just had a superficial biopsy, it would be really hard if, say, your biopsy was there to be able to tell that this was squamous cell carcinoma. So on sun-damaged skin, particularly on the extremities, I'm really wary when I see an open cystic space with keratin coming out of it, even if there's not much atypia, because a lot of times that's the way squamous cell carcinomas look superficially, but when you go down deeper, you can now see that there's clearly nests of invasive squamous cell carcinoma going down into the dermis. And let's look at those. So the degree of cytologic atypia can vary quite a bit in squame, and that's one problem. When it's obviously markedly atypical, then it's a little easier to tell that it's squamous cell carcinoma, but some of them can be relatively bland and glassy, and that can create a problem. This right here that we're looking at, this little nest of keratinocytes that has perikeratosis in the middle, this is called keratin pearl, this swirl of perikeratosis. Let's see if we can get it in better focus here. This swirl of perikeratosis trapped in the middle of a nest of invasive carcinoma, and there's atypical, hyperchromatic, large nuclei around the periphery of the nest as well. And then you can also see there's nests of invasion over here. But these keratin pearls are a very characteristic feature that we often see, but not always, but we often see in squamous cell carcinoma. And here's another kind of larger one right here. And usually there's a connection with the surface, although not always is it obvious that there's squamous cell carcinoma in situ over top. For example, look up here. We can tell there's invasion down below and that the lesion connects to the surface, but the surface here really looks just reactive. It has like a Lichen simplex chronicus change from chronic scratching and rubbing and picking at the lesion, thick granular layer, but really very minimal atypia. There's no AK or squame in situ here, and yet we have invasive squame. So again, this is where there's not always a stepwise progression to invasion from AK to squame in situ to invasive squame. A lot of times you really don't find much overlying precursor lesion. And then sometimes also what you get is right here, squamous cell carcinoma only in the dermis. Now, the problem with this is that this is what a metastatic squame would look like if you had, say, a lung, a squamous cell carcinoma of the lung or some other site in the body. If that metastasized the skin, it would make a nodule in the dermis with no connection to the epidermis. But depending on where you section through a primary cutaneous squame, sometimes out at the periphery, you'll see areas like this that just invade the dermis. So the clinical is important. On a biopsy, if I see this, I will think about the possibility, could it be a MET? But I all the time see cases where there's just dermal squame, and it's because right next door to that, there's connection to the epidermis. We just can't see it in the area we've sectioned because it's kind of a crater shape lesion. All right. Here's another example, and again you can see from low power the nice pearls, the keratin pearls as you go down into the dermis there. And here's more of them. And they're these swirls of perikeratosis. There's often a lot of inflammation around squamous cell carcinomas. That's a common finding, and there may be variable amounts of fibrosis and desmoplastic stromal reaction in the dermis. Right here you can see that. Let's see if we can get it to show up a little better. So here's the squamous cell carcinoma, the islands of tumor there. And then down below that, there's all this reactive fibrosis and mixed inflammation that's basically the stromal dermal reaction to the invasive tumor. So sometimes that can be helpful to find that reactive stuff to help you know that you're dealing with nests of actual invasion rather than just in situ pushing down a follicle or an adnexal structure. All right, squamous cell carcinomas sometimes produce a massive amount of perikeratosis over top, and that's what forms a cutaneous horn clinically. And I've got a video about cutaneous horns you can check out. I'll put a link down below in the video description. But that large thick layer of para over top looks like a horn clinically. Horns, you can have squame underneath them. They can have squame in situ or invasive squame, but they can also have AK and other lesions. So there's really no way to tell what's making the horn unless you see underneath it. And in this case, there's clearly invasive squamous cell carcinoma down beneath it. And you can see the tumor cells pushing down into the dermis. And in this case, they're quite dramatically atypical. And you've got big, ugly, pleomorphic nuclei. And you can see mitotic activity as well. But you don't always have these features. And again, note that the dermis has like a fibrotic, desmoplastic appearance, which is helpful in recognizing the diagnosis. And look at how pink and glassy the cytoplasm is here. So again, when squames invade the dermis, they begin to turn on, paradoxically, more of that mature keratin, the keratins 1 and 10 that you see in the spinous layer of the epidermis. And that makes the invasive cells often have a more abundant, pink, dense, what we call glassy cytoplasm. And so when I start seeing that appearance at the base of a squam in situ or an AK, it makes me wonder if there's invasion underneath. And there's a really great example. Look at that cell. That cell's got enormous amounts of bright pink keratin in its cytoplasm. And a very atypical nucleus. Okay, this lesion is a lot more basaloid and blue in appearance, and sometimes these can be a little bit hard to tell apart from a basal cell carcinoma. But I think that a couple features that help me is seeing the keratinization in here. You can see the pink areas of keratin. There's not really any basal palisading or clefting around the outside of the nest. There's marked atypia, which you can have in basal cells. Basal cells can be pleomorphic. But when I see really ugly cells and then also see some keratin production or kind of pink cytoplasm, sometimes you have to go a little closer to tell that, and then it depends on your H&E from lab to lab. Those things can help. But there's really dramatic pleomorphism in some of the cells in this squame right here. And again, look, it connects to the surface, but really the adjacent epidermis shows not really much in the way of AK or squam in situ. Here's another look showing the really abundant atypia. Squams, I think, have some of the wildest atypia in human cancers. And squams and, I guess, high-grade sarcomas, which is interesting because cutaneous squams, even though they look really ugly sometimes, most of them are pretty indolent, except when in certain sites or if they're really large and deep. And then here's a tripolar mitotic figure, which you often have very strange, bizarre mitotic figures in squamous cell carcinomas as well. And this case is pretty nicely shows a progression. So sometimes you do see a progression. Oops, sorry, there we go. Over here we have what looks like actinic keratosis with partial thickness atypia. Then you have areas like this where you get invasion, and again, look at how pink and glassy the keratinocytes get when they invade the dermis. They get a bunch of that pink cytoplasm. You can see here's a squame right here, and then here's little islands down here that are invading as well. So that's why it's really important to, and look, if you just had a shave biopsy that showed this, you really wouldn't see the invasion. You would just see this kind of crater-shaped lesion with keratin in it. So again, that's why I like to really be careful in that, that setting. And then here's a nice example that you can have a couple things here. This is one area that you have a bunch of keratin and it's making a cystic portion of the lesion. And so squames can sometimes mimic cysts. Now, if you're lucky, you'll see atypia in the cyst wall, and a lot of parakeratosis in the cyst lumen, but sometimes you won't. So if I see a big cyst that's real close to the skin surface, particularly in the very sun-damaged extremities, like on the dorsal hand or forearm, I tend to be kind of cautious in that setting and worry that maybe I'm getting either the top of a cystic squame or at a keratoacanthoma, which we'll talk about in a separate video about what to do with keratoacanthoma. And here you can see there are areas that are a little bit more easy to appreciate that this is clearly invasive squamous cell carcinoma. There's keratin pearls right here and there, but then underneath there's this big cystic component. The other thing I want to point out about this lesion is there's invasion all the way into the deep dermis and pushing down into the subcutis. Now look on this piece. Something I want to point out, anytime you see tumor that's pushing out, I guess here, you see tumor that's pushing out way beyond the rest of the lesion, and you can see kind of a tongue of tumor coming down into the subcutis, or if you see islands of tumor invading out away from from the rest of the lesion, always think about perineural invasion in that setting, because sometimes when you have tumor that's way out away from the rest of the main cancer, and that's not just for squames, that can be for basals or for other types of cancer, that can be a sign that what you're dealing with is perineural invasion. And in fact, look at this down in the dermis. We see an inflamed nerve. An inflamed nerve, or a nerve with a lot of myxoid change, should always kind of raise concern for maybe there's perineural invasion in that nerve. And indeed, that's exactly what's happening here. You can see the little nerve. You can see there's nerve here, and it's completely wrapped and surrounded by malignant keratinocytes. So there's perineural invasion, and then note all the inflammatory change around the nerve. So sometimes I've seen that before where I had a nerve with myxoid change and perineural inflammation, and only on deeper sections did I find that there was actually invasive carcinoma wrapped around the nerve. So those are kind of clues to think of perineural invasion. Here, let me show you on the deeper slice. I think here's a deeper section of that same tumor. And you can see here's the tumor invading, and then right down here, here's nerve, and then the nerve kind of tracks down into the deep dermis, and there's tumor around it at all of those points. So this is the same nerve. It's kind of waving and coming in and out of the plane of section, and so that's why we're not seeing all of it. You have to think in 3 dimensions in pathology. So there's tumor right here, and there's nerve that it's wrapped around. These are eccrine coils. Sweat ducts, or sweat coils, excuse me. And then here's tumor right here, and again, tracking right along the nerve. And you can even see, let's see if we can go in high power and show you. In these a little bit larger nerves that we see down in the subcutis, you can actually, if you're lucky, you can see the little axons, the little pink threads of nerve axon that are going through the nerve itself. And then the spindle cells there are Schwann cells, of course. So this is perineural invasion in a squame. And squames with perineural invasion have a tendency to be more aggressive. Here's tumor, and it's close to the nerve. So here's a nerve, and then here's tumor right next to it. When I see that, even if I can't find tumor in the nerve, sometimes I'll mention that there's an area suspicious for perineural invasion. The reason it's important to bring up perineural invasion, at least in the head and neck, there is sometimes consideration for doing radiation therapy for squames with perineural invasion. Now, there's some debate about when to do that, how much nerve has to be involved, or if it's a large nerve. But the point is it's good to bring up, because then that discussion can be had with the clinical team. The other reason is that anytime you have perineural invasion, there's potential that the tumor has extended out beyond the margins. So you might have negative margins, technically, like you've looked at all the margins and they're negative, but there still could be tumor that's skipped past, along the nerve, skipped past the margin, and is still there in the patient. And I've seen that before, a patient that was cleared by Mohs and then had a recurrence. They were cleared by Mohs again, then they had a recurrence. And then finally we looked at the Mohs permanent sections, couldn't find anything but cut deeper, and after the clear layer, there was a nodule of perineural invasion. And so that was, to me, a perfect example to see that really helped me to understand this is how perineural invasion can behave clinically. And then there again is that same piece we were seeing in the other section. So really, seeing the perineural invasion is partly about getting lucky and having the right section show up that goes right through the nerve where it's involved. So it's important to have a high index of suspicion for this and make sure that you don't miss it. Now here's a problem that we encounter very often in squamous cell carcinomas, or in Dermpath. This, what I'm showing you right here, basically looks like a prurigo nodule, or Lichen simplex chronicus. Thick, irregular acanthosis of the epidermis, long, reedy ridges of varying length, not much atypia, and a massive, thick granule layer with thick keratin over top. This is what chronic scratching and rubbing looks like, okay? The skin reacts and it gets more kind of acral in appearance. It looks like skin of palm and sole when you scratch and rub it. And the problem is that, like I mentioned earlier, any actinic keratosis or squame or any other lesion for that matter, people tend to pick at them and they get this change over top of them. And so again, I particularly see this on the dorsal hand and forearm of elderly sun damage patients. If you see this kind of change and there's any atypia and it's transected, I tend to be a little cautious. Like, what if I had this? It's pushing down a little. It's got a bunch of keratin production. It's got a little bit of glassy, kind of expanded pink cytoplasm, but I don't see anything that looks like obvious squame there. It really doesn't even look quite right for actinic keratosis, but look what happens when we go deeper. It's clearly an invasive squamous cell carcinoma right here. I see this multiple times every single day. So we can only do what we can as pathologists. We can only comment on what's available on the slide. But if I have concerns and there's some atypia there, this is the kind of time where I add a comment that, I can't see the base of the lesion. And if the lesion persists or recurs, then a repeat biopsy may be indicated. Just to let my colleagues in derm know, hey, keep an eye on this lesion. I don't see any obvious malignancy here, but it's possible that down underneath we may not be seeing the entire lesion, because this often happens where this area looks like a good area to biopsy, and a derm may get a nice, what they think is a thick biopsy, but again, it may look thick because of the massive keratin over it and not actually be sampling much of the dermis. So the deeper a shave that you can get on a keratotic lesion, the more likely the dermatopathologist will be able to give a definitive diagnosis. So, and here's more of the squamous cell carcinoma here. And again, look, what if we just had a shave through here? It's a fun and scary game to play of what if we just had this in the biopsy. And I think even though it's a little terrifying, it also helps us to learn how to have that index of suspicion, when to worry, and what could go wrong. So trying to kind of artificially create that scenario to help us see, oh, if I only had a biopsy here, there's no way I would know that there was cancer underneath. I mean, look at that. That looks like textbook in the middle. That is textbook for Lichen simplex chronicus or prurigo nodularis, which really are just the same thing, just different clinically. But then underneath it, invasive squamous cell carcinoma. And look at again how glassy and expanded the cytoplasm gets as the tumor cells invade the dermis. And then here's an example of this very open cystic change that you can have at the top of a squame. So again, what if we just had this biopsy? You might say, oh, it's the opening of a cyst or a dilated follicle. It's got loose, flaky keratin in it. It doesn't have any atypia really. But then if you go down below it, ta-da, squamous cell carcinoma. So again, I tend to be really wary of large cystic lesions, particularly on the dorsal forearm and dorsal hand, and particularly when cysts have a big, broad opening with the surface in sun-damaged skin. I find that cysts oftentimes have small openings to the surface, a punctum, but to have a really broad open cyst that comes up to the surface in badly sun-damaged skin, to me that's concerning that there could be something worse. And again, that's the kind of time where I'll add a comment that, this could be a cyst. If I'm, depending on the situation, I may say this could be a cyst, but I don't see any atypia, but I can't see the base of the lesion. Or if I'm kind of concerned about it, I'll end up saying this is an atypical squamous proliferation, and I'm not sure if it's reactive or a cyst, or if it's actually the top of a squame, and I want you to go back and excise it or do an additional biopsy. So depending on my level of concern and the clinical situation, I alter my comments accordingly. And you've got to do what works with your practice and with the dermatologist in your area to make sure that whatever you're communicating in your report, they understand and they know what to do with it. And that's again why it matters to have that rapport with your clinical colleagues who are treating the patient. Here's another really great example of just how dramatically cystic these lesions can look. A big open kind of crater, and this one's filled with a lot of perikeratosis. And if I see a big cyst with a lot of para, that's usually very worrisome that there's a squame underneath. I'm sorry, I'm having trouble getting the lighting correct here because of all this keratin. And then over here you can see next to the cyst, islands of invasive squamous cell carcinoma in the dermis, massive solar elastosis from all the chronic sun damage that they have, and over top, again, LSC, Lichen simplex chronicus change, really, really common to see that next to squames and actinic keratoses. And here you could really tell out here at the edge, look at all of this infiltration. Very little tiny nests of squamous cell carcinoma infiltrating out into the dermis and invading everything around them. So sometimes squames can be very infiltrative and sneaky. And here's some keratin pearls down here. So here's a situation that we encounter from time to time. This is kind of like what I showed you before, but here we really do have a superficial biopsy, and it's hard to tell. Right away, I'm concerned for squamous cell carcinoma because I see big expansile, glassy, pushing keratin nodules going down into the dermis, but I can't really see the base. And the reason I want to be cautious in a scenario like this is because sometimes reactive squamous proliferations can make this glassy expansile look, what we call pseudoepitheliomatous hyperplasia, or PEH. So pseudoepitheliomatous hyperplasia can happen as a reactive phenomenon from a ruptured cyst or from prurigo, from picking and scratching. It can also happen in the setting of certain infections like invasive fungal infections like chromoblastomycosis, pheohyphomycosis, blastomycosis. I've seen it in a leishmaniasis. A variety of different infectious things can cause this, as well as bromoderma and iododerma, the halogenodermas, and others. So there are many different things that can really look very similar, almost identical to squamous cell carcinoma, but are actually benign and reactive. Now here, I'm pretty sure this is a squamous cell carcinoma, but it's worth thinking when you see big glassy expanded areas, and when you see little clusters of neutrophils. That's a thing that I sometimes see in, that can make you think about infection. I see that in squamous cell carcinomas all the time as well, but I always want to stop and think, could this be infectious? Is there any chance that it might be? And those are times where doing infectious stains might be helpful, depending on the situation. I'm pretty concerned about this one though, but if I'm having trouble deciding if I should call it definitively a squame, or maybe the top of a keratoacanthoma if you like, and again, we'll talk about that in another video, but I tend to still usually refer to those as a variant of squamous cell carcinoma, but that is controversial, and we'll address that separately. But if I'm not sure, if I'm worried and I think it's atypical, but I'm not sure, that's when I'll say atypical endophytic squamous proliferation, with a comment that this could be reactive, but it could also be the top of a squame, and I'm really not sure. And if they're worried clinically, they need to go and excise the lesion, or at least watch it really closely. So here over to the side, there is a lot of Lichen simplex chronicus change, as well as a bit of actinic keratosis right here. This is the kind of atypical basilar atypia, but still maturing, and this is AK, and then next to it is a lot of changing from chronic scratching and picking. All right. I think in reality I actually just called that case squamous cell carcinoma, but it's one where it's worth thinking about. If you're not sure, the way to deal with it is to use some comment about your uncertainty, and then help your dermatologist know what you'd like them to do. And then here's more examples along the same lines. If you had the top of this, you could think about a prurigo nodularis, or you might even think about a verruca, a wart. It's got some papillomatosis, some finger-shaped projections. It's got parakeratosis in spires, like right here. A nice spire of dense keratin with some para, and then also some loose ortho around it. You've got dilated vessels in the papillary dermis. So all of these are good features for a verruca vulgaris, a wart. But then look what happens as you go deeper. Obvious squamous cell carcinoma. Now, is this a wart that turned into a squame? I don't know, maybe so. But I see things that look warty on top and actually down at the base have squamous cell carcinoma. I see that regularly. So what the rule that I've learned is, just like with cysts, particularly in the dorsal hand and forearm area in sun-damaged regions, I'm really concerned about making a diagnosis of verruca in old sun-damaged people on the dorsal hand and forearm, particularly if I can't see the base of the lesion. So sometimes what I'll do is, if I see something, say it was transected like this, I might say, oh, this could be a verruca, but there's a little atypia, and I'm not sure if that's reactive or if there's something worse underneath, and if it continues to grow or if there's clinical concern, then please either rebiopsy or excise it. Sometimes I see things that look perfect like a wart and have no atypia, but again, they're transected at the base and it's an old sun-damaged person, and I'll make a comment that I don't see any atypia, but I can't see the base of the lesion, and so I'm just really wary about diagnosing a verruca when it's transected in chronically sun-damaged skin, because I see this, again, multiple times daily. I see this in my practice where it looks like a wart on top, and then down below there's invasive carcinoma. So that's why I think it's worth just being a little more cautious. Now, in someone who's 25 or 30 years old and it's on their finger and it clinically looks like a wart, I'm not really worried if I can't see the base there. It's really just in these older sun-damaged people, because yes, they can have warts, but they often have squamous cell carcinoma that looks like a wart on the surface, and then only down deep can you tell, yeah, this thing is definitely not a wart. There's absolutely atypia and invasive growth, and this is clearly squamous cell carcinoma. So just be careful of that, and let me show you one more example that I think really demonstrates it very nicely. I mean, this one really just on the top, that looks perfect for a wart. It's kind of a dark stain on this one, but it really does look very verrucous. Really doesn't have, these tips don't have much atypia at all. I mean, they really look just fine for Verruca vulgaris. I mean, that'd be perfect. I think I used this case as a picture in my Dermpath survival guide book because it really looks very warty, or maybe you could even argue that it's like kind of a seborrheic keratosis appearance on top, but then go down deeper and what happens? Obvious atypia and invasive growth, and now there's no doubt we're dealing with squamous cell carcinoma. So I think you get the point, is that just be careful in superficially sampled keratinocytic lesions because they can really be treacherous and very much look benign even though there's atypia and invasion and malignancy down below. So let's talk about a few other variations morphologically of squamous cell carcinoma. So here's a nice obvious squame, very nice and glassy, good invasion, nests of invasions down there. But look at all this dark blue stuff around it in the dermis. And this is brisk inflammation and not only of lymphocytes, but also many, many plasma cells. So I think I mentioned earlier that plasma cells can just be florid. They can be numerous underneath squamous cell carcinomas and also underneath basal cell carcinomas. It's a little hard to get them to show up because of their color here. Let's see at high power if they show up. Yeah, there are tons of plasma cells here. So again, I don't usually go doing kappa and lambda-ish or anything like that. I just see this all the time. Tons of sheets of plasma cells underneath a lesion. And I also see a lot of inflammation, but that said, if you see a bunch of like lymphocytic inflammation under a squame, that's a common finding. But if they happen to look very uniform and round, I have seen a handful of times where there was chronic lymphocytic leukemia or small lymphocytic lymphoma, CLL, SLL, adjacent to squamous cell carcinoma. And I've seen some cases where the squame behaved very aggressively clinically because the patient had undiagnosed CLL and it was basically wiping out their immune system. And so the squame was kind of running uncontrolled, almost like the patient had had a transplant. Transplant patients tend to have squames that are very aggressive as well because their immunity is diminished, and patients with CLL have diminished immunity. So if you think that there's a bunch of lymphocytes more than usual and they look very uniform and monotonous, have that kind of soccer ball appearance of CLL. I'm not very good at hemepath, but I feel like a CLL has kind of a look. The lymphocytes look very, very monotonous and uniform. And in those settings, I will actually do some additional stains like a CD3, CD20, CD5. And if they're a bunch of CD5 positive, CD20 positive B cells, then that's when you need to do more workup and have them clinically worked up. But just plasma cells by themselves, I don't get too worried about that because I see that all the time next to squamous cell carcinoma. Here, this squamous cell carcinoma is falling apart, and it leaves all of these open spaces here. And these spaces are filled with keratinocytes that are rounded up and very, very pink, and they have smooth, round borders. And so this is a squamous cell carcinoma with acantholysis, or what we call an acantholytic squamous cell carcinoma. And these are important to recognize. In the past, people thought that these were more aggressive. Some recent studies, though, have not found that to be the case. But I think that it's still important to recognize it because this variant can be confusing if you don't recognize what it is. I've seen acantholytic squames that really looked like they were had gland spaces or vascular spaces, and so they could easily get confused with adenocarcinoma or even angiosarcoma if you weren't familiar with the pattern. The thing I find most helpful is that in the spaces you have the floating round pink keratinocytes, these acantholytic keratinocytes. And this is a similar pattern to what you see in a variety of acantholytic diseases in the skin, like Haley disease, Derrier disease, Grover disease. It's the same pattern, it's just happening here in the setting of a squamous cell carcinoma. And you can also see this in squamous situ and in actinic keratosis sometimes, but here it's invading down into the dermis. So this is a really nice example, I think, of acantholytic squamous cell carcinoma. And just know that they can sometimes mimic other things outside of that look. They can sometimes mimic adenocarcinoma and angiosarcoma if you're not familiar with them. And immunostains, if you're having trouble, immunostain can easily tell this apart because this would be positive for P63 or P40, and also for cytokeratin 5/6, which wouldn't usually stain an adenocarcinoma and certainly wouldn't stain an angiosarcoma. And And here's a squamous cell carcinoma, again, kind of a little bit of a warty look on the surface, and underneath, very infiltrative growth. So I like to mention when I see really striking infiltration, little cords and strands and tiny nests of tumor invading down with a real dense fibrotic stroma, kind of similar to the pattern that you see in infiltrative or more morphiiform, if you like, basal cell carcinomas. I feel like sometimes we see a similar growth pattern in squamous cell carcinomas. And I like to mention that I suspect that these are more likely to be locally aggressive. I don't necessarily know if that's always true, but I worry that they might be. And I also worry that my colleagues in Mohs surgery, if they have to see these, that it would be easy to miss little tiny single cells of invasion or little strands of invasion. Now the stroma, I think, on the Mohs section can help, but I think, look at how easy it'd be. That's a tumor cell right there. It's got a big atypical mitosis. Look at that. Big atypical mite. So that is an invasive tumor cell there. And then over here also we've got little nests and islands of invasion that are very subtle. There's a single tumor cell up here in the corner. So I think it's worth bringing up this when I see this, and I call it squamous cell carcinoma, invasive, infiltrative growth pattern, just to let anyone who's treating it know that this tumor is very infiltrative. I don't have a definitive line where I decide if something's infiltrative or not. Just kind of like with basal cell carcinoma, it is a bit subjective, but I think if I notice it and think, ooh, wow, that's really infiltrative, I usually feel like it's worth bringing it up just so that my clinical colleagues will know about it and can take that into account when they're deciding about treatment. And then usually I do not give a differentiation for squam. I don't say squamous cell carcinoma well differentiated. I just say squamous cell carcinoma, and I don't mention differentiation unless there's something other than usual. Most squams that I see in Dermpath are well differentiated, but if I see ones that look uglier and more sheet-like and atypical, then I will mention if I think it's moderately or poorly differentiated, but I don't usually say well differentiated. I know some people do. This is just my personal style. I'm not saying that you have to do it. So over here, nice glassy, obvious squamous cell carcinoma. That I would say represents well differentiated, right? When you see squamous cell carcinoma and you know obviously that's squam, well then that's well differentiated. When you start seeing kind of sheet-like areas where the tumor gets a little more ugly, like say right here, probably that's fine with squam, but if you just had that, you could start thinking, gosh, it's very sheet-like. Is there any chance this could be something else like melanocytic? Probably not, because it's still making pink cytoplasm because of the keratin. And if you go right next door, you can see that obviously there's definitive squamous cell carcinoma here, no problem. But when I start getting really ugly sheets, but I can still tell it's squam, that's when I'll sometimes say, oh, there's moderately differentiated or well to moderately differentiated squamous cell carcinoma. I'm not totally sure if that has any definitive prognostic or behavioral difference, but again, I think it's worth mentioning. And also because if the tumor recurs or metastasizes, if there's uglier areas here that could be a little bit tricky, if only that area happens to spread or recur, then the next pathologist who sees the case may struggle to recognize it as squamous cell carcinoma. And I've seen squamous cell carcinomas and melanomas get mistaken for one another. I've seen that those kind of mistakes can happen. And so it's important to think about that even though usually it's easy to tell this apart on H&E, there are times where squams can mimic other tumors and vice versa, and that can really have a dramatic impact if there's a misdiagnosis. So it's important to do anything that we can to help avoid that risk. And if I see something that I think might confuse someone else in the future, then adding a comment to explain that is probably a nice thing to do and might potentially improve patient care, I think. Like, see, look at that. This stuff gets pretty ugly in here. You could really have a little trouble being sure that that's squamous cell carcinoma if you just had a field like this. Again, it probably is, but again, if you just had this, it might be difficult to tell. Now then, cases like this, I would call poorly differentiated. And this is a huge, massive tumor. Big, ulcerated, fungating nodule. I think it was on the ear, if I recall. And here, I mean, the tumor cells are so ugly that, I mean, that could be, and they're kind of spindled. So this could be a spindle cell melanoma. It could be maybe an atypical fibroxanthoma or a pleomorphic dermal sarcoma. It could be a lot of different things. It does have a little bit of pink color to it, but really you can't tell for sure that it's a squamous cell carcinoma. In here, the cells get a little more oval to round, and so you could start wondering, well, maybe this is actually epithelial, but I've seen areas that look just like that in melanoma and in a variety of other tumors. So when you've got sheets of ugly cells that you really can't tell they're keratinocytes at all, and that when you look at them, you think, I need to do immunostains to see if this is squame, usually that's the time when I'll say poorly differentiated. If it's so ugly that I have to do an immunostain to prove that it's squamous cell carcinoma, that's when I usually will use the term poorly differentiated, that it's so ugly I can't even tell for sure that it's keratinocyte without getting some help. Now in this case, we probably can, because if you look over here, what do we see? There's actually obvious squamous cell carcinoma here. There's nests of squamous cell carcinoma that have some kind of glycogenated clear cell change, but definitely this is epithelial here, and then it's transitioning into this ugly sheet-like poorly differentiated stuff. So if you want, you could say that this is a squame that has a sarcomatoid differentiation, or some people use the term carcinosarcoma. I feel like those terms can be a little confusing sometimes, particularly to dermatology colleagues who may not see them very often. And we've used them elsewhere in the body and pathology, but sometimes I feel like if I say it's a squame that's moderately to poorly differentiated, or that it's poorly differentiated and it has spindle cell component, I feel like that's more easily understood. We're dealing with a really nasty high-grade squame, and that's how it's going to behave. Certainly something like this could be aggressive and could metastasize, but I wouldn't want someone thinking they need to treat this like a sarcoma. It needs to be treated like a really bad squame. But it is worth bringing up, I think, when there's spindle cell component. And in a case like this, you could say, well, we don't need to do any immunostains because there's obviously areas that have clear-cut squamous cell carcinoma, like right here, right? We've got nests of squamous cell carcinoma here. But that said, it's been reported that you can have melanomas and squames grow next to each other. You can have atypical fibroxanthoma or pleomorphic dermal sarcoma grow right next to squamous cell carcinoma. The most likely thing is that this is a squamous cell carcinoma that's turning into an ugly high-grade tumor. But if I have any doubt, doing some stains can help. Here's an area where you're getting a little bit of that acantholytic pattern. The cells are falling apart, and again, that could be confused for vascular channel formation or other things. So there's a real wide range of features in this particular case. There's round cells and sheets, spindle cells and sheets, a little acantholysis, and then some intact, obvious glassy squamous cell carcinoma here. So this is one that I said was poorly differentiated squame that had spindle cell features, and again, a little bit of that acantholytic pattern where it's falling apart. So just a wide range of patterns that you can see in squamous cell carcinoma. When I see a squame that's poorly differentiated, really ugly, or really deep, if it goes into the subcutis or deeper, I tend to usually add a little template of additional features. I say the tumor thickness is however many millimeters from the surface down to the deepest invasion. And I say if I know that the tumor invades into the subcutis. And the reason I do that is that there is evidence that deeper squames and squames that go into the subcutis tend to behave more aggressively. And also it helps that my dermatologists who are used to seeing many reports that say squamous cell carcinoma invasive every day, if I stop and say, oh look, this tumor is 5 millimeters in thickness and it invades the subcutis and there's perineural invasion and it's moderately to poorly differentiated, then that tells them, whoa, wait a second, this is not going to be our average squame. This is one that may be really aggressive and we need to do something more about this. Make sure we get this patient either Mohs surgery or get them into someone who does surgical oncology to do a bigger definitive resection. So I feel like really nasty squames where I'm worried that they're going to be more aggressive, I want to add some comment to help my dermatology colleagues know this is a squame that I'm really worried about. And that's kind of how I do it. And look there, huge atypical mitosis in this squame. I mean, you could almost karyotype it and that thing is got like 500 chromosomes. Really crazy wild atypia and mitoses that we can see in squame. And this is a great example of poorly differentiated. Looking at this field, you'd have no way to be sure that this is squamous cell carcinoma on this field alone. You'd have to do immunostains to prove it. So I would say when you've got areas like this, you can confidently call it a poorly differentiated squame once you've proven that it is actually squame and not something else. So I hope this video has given you some help into how I approach actinic keratoses, squamous cell carcinoma in situ, and invasive squame, and some of the pitfalls and the tips and tricks along the way. Again, if you want more information about keratoacanthoma, which I kind of regard as, or usually call a subtype of squame, but if you want to talk about that controversy, I'm going to make a separate video, and once that's ready, I'll put a link down below along with the additional links I mentioned during this. Be sure to check out my dermatopathology survival guidebook if you you want more basic approach to Dermpath, I'll put a link to that. And then if you haven't yet, please subscribe to my channel and click like on the video and leave any comments or questions you have down below. Thanks for watching.